Thanks, Shomo, for the nice introduction. Now it's my turn to have the pleasure of introducing the next speaker, Dr. P. Ravi Kumar, who is the Chief of Endocrinology at the Arca Diabetes and Endocrine Center. I'm sorry, yeah. Uh, and he has 20 publications, including paper in prestigious JCE and AIM and diabetic medicine. And he was the organizing secretary for ASICON 2019. Without wasting any further time, may I invite Dr. Ravi to present his paper on insulin optimization and intensification. Over to you, Ravi.
Thank you, sir. Professor Satynath, sir. Thank you, organizers. It's a wonderful to have give a talk in a very prestigious conference. I'm also thankful to the Sanofi asking me to speak on this. So I'll be sharing my screen. Is it visible? I hope it is visible. Yes.
Yeah.
So it is an old topic. I have been asked to speak on insulin optimization and intensification, a stepwise march towards glycemic goals. So this is an old topic, but debate always remains which to what to start, how to start, when to start. So I'll be just presenting what are the facts and data. So before that, just to look at a typical patient which comes to our OPDs in every day, that a 56 years old male, he has presented for diabetes for last 8 years without any complications, either hypertension or any heart disease or any chronic kidney disease, with a normal blood pressure, normal pulse, and he is having a A1C of 8.3% with uncontrolled glycemia with fasting of 196 milligram per deciliter, postprandial is 236 milligram per deciliter, and he is already on 3 drugs, metformin 1 gram twice daily, imiprid 2 milligram twice daily, and sitagliptin 100 milligram. So what next we should do it? Shall we add the question always comes to many of us, what should be the next line of therapy? In clinical practice, it has been seen that many of the patients were actually reluctant to initiate insulin, and many of the doctors also either knowingly or unknowingly, they go on adding the 4th oral drug. So is there any beneficial effect of the adding the 4th oral drug to already somebody is on triple drugs on for type 2 diabetes? Now, what does the evidence says? This is a study, this is a Indian real world setting study. This is ongoing trial. The first 6 months results have been published in ADA 2020, and it has been seen that patients who are receiving 3 or less than 3 drugs, oral drugs, they were compared with people who are receiving 4 or more drugs. And what you see, what is the change in A1C? You can find that there is a decrease of 0.3% decrease in A1C in people who are receiving 3 or less than 3 drugs compared to only again 0.3% among the type 2 diabetes patients who are receiving 4 or more drugs. This means if you add another drug, oral drug, it is unlikely to have a much greater benefit in type of patient. Now, compare this within the same trial, we find that when the insulin naive patients who are on oral drugs, when they compared with the people on insulin, in the same period of 6 months, it has been found that there is a significant difference in the A1C reduction. You find that 0.3% in people with on insulin naive patients, whereas 0.6% on insulin as expected. So this is clearly shows that it is a time that when somebody on triple drugs and his A1C is uncontrolled, it is better to go for a insulin. Now, we all know that what are the indications for starting the insulin. Any patient who is on oral drugs, double, dual or triple combination with uncontrolled A1C of maybe around 8.5 or 9%, and people with severely sarcopenic, hypoxic, or having the very much symptomatic with osmotic symptoms or suffering from complications, definitely we would think of insulins. The next question that comes to mind is which insulin to initiate in type 2 diabetes? This used to be the previous debates. Now I think it is more or less, of course, not at rest fully settled. So whether you go for a basal or a premix insulin, in Indian settings, it has been advocated even by the Indian guidelines way back in 2014 and 15 that premix is better than basal insulin in Indian settings for the simple reason that Asians tend to have a more of pronounced postprandial hyperglycemia compared to the Caucasians. And postprandial hyperglycemia being one of the important indicators for ROS or reactive oxygen species and the complications, it was advocated that premix insulin may be better for basal. Now, there are also other options like Basal-plus or Basal-bolus. So we'll be just looking at some of the evidences. So what does the guidelines say about it? The guidelines, we have got various guidelines by various bodies, and most of them are unanimous in starting with the basal insulin compared to the premix insulins. Now, the previously what used to be ENDIAB guidelines in 2012 or till 2014, they used to say that you start with the basal insulin, and if A1C gets uncontrolled, add a bolus insulin. Usually start with one bolus rapid-acting insulin for the largest meal, or you can go for a pre-mixed insulin twice daily. This is the initial combination, but they also said that it is a less flexible pre-mix compared to the basal insulin. Now, the recent 2021 guidelines, which says that if A1C gets uncontrolled, you start with the basal insulin, usually at a dose of 0.1 to 0.2 units per kg. And then if A1C is again uncontrolled, say maybe around after sufficient basal dose has been given or titrated, and still A1C is uncontrolled, we have got three triple options: adding a GLP-1 receptor agonist, or making a basal to basal plus, or converting if you are already on NPH, converting it into twice daily NPH. And the question of adding a premix insulin has been actually lower in the order. That's what, because for the simple reason it becomes a bit less flexible and the chances of hypoglycemia may be more. Now the ACE guidelines again, they say that start with the basal and intensify with basal plus 1 to 3 or basal bolus. But again, premix has not been indicated. So why basal insulin as the first line? But I would just say there are many reasons why basal has been initiated in many of the patients, because it is very simple and convenient to start with the treatment, and there is a lower risk of hypoglycemia and weight gain. These are the two main reasons why it has been advocated as the basal insulin. Now, if you first control the fasting plasma glucose by titrating the basal insulin, you find that once elevated fasting is controlled, there is of course seems to be decrease in the postprandial glycemia also. Now, this is another trial, the same trial of Indian landmark trial, which has shown that people on basal insulin, once you control the fasting glucose from 154 to 135, there is also significant reduction in the postprandial glycemia also, from 228 milligram per deciliter to 191 milligram per deciliter. It certainly shows that even in other studies, it has been shown that people who are adequately treated or titrated with basal insulin, there is a chance of around 50 to 60% might not require the prandial insulin. Another 40 to 50% definitely require a prandial insulin for control of glycemia. This is a study of comparing the basal insulin plus OAD, that is sitagliptin versus premix. This is a 24-week study, and has been clearly shown that people achieving A1C of less than 6.5% was higher in people with glargine compared to premix. And the added advantage is there is a less risk. There is a 4.5 times lower risk of hypoglycemia compared to on premix, and also the weight gain is less, and more importantly, the adherence to treatment is also better with glargine plus OAD. So somebody who is on triple drugs and is not able to get in control, it is better, it makes sense to start with a basal insulin, probably a 24 hours long-acting insulin, and very eloquently told by Dr. Nilanjan sir regarding the newer insulin, they have got very beautiful profiles. Now, this is another trial again showing the same thing, the 24 weeks trial comparing the glargine with OAD versus premix. You find that a better control with A1C and less risk of hypoglycemia. There are also other trials where it has been shown that premix is better than basal in initiating this, but consistently it has been shown that the hypoglycemia risk, the weight gain, and the insulin doses were definitely lower, better placed with the basal insulin. Now, our patient, what we discussed initially, is a 56 years old male who has an uncontrolled A1C of 8.3%. He is on triple drugs. So what we should do is we should go for a basal insulin, and based upon his weight, 60 kg, a zero point 0.2 units per kg of basal glargine 100 has been started at 12 units at night. It has been started at bedtime, and you find that the A1C the A1C remained the same, but FEG has come down from 196 to 162 at the first month, and the postprandial has also come down from 236 to 184, and is further increased to 14 units. So it is one way of addressing the problem, people on OADs and not getting glycemic control. Now, need of systemic dose of titration is very important in optimization of the treatments. And it is a study where it has been seen that people with type 2 diabetes who could able to achieve A1C of less than 7%, it has been shown that those people who are on glargine 8.5 units per day and progressively they have been titrated to 13.7 units per day, the A1C and fasting glucose, they have come down remarkably and very significantly. So titration is of very important in once you start with the basal insulin, and titration various regimens are there, but the one which more commonly followed is 80 to 130. You don't have to change anything, and further you can add 2, 4, or 6 or reduce depending upon the fasting plasma glucose. Now, titration inertia is one of the important problem with both with the physician and people with diabetes for various reasons. And we all know that there is a weight gain, fear of hypoglycemia, and some of the physicians might feel that there is a complex algorithms and regimens which actually inhibits many of them to start with a insulin or up titrate the insulin. Now, this is an ATLAS study where it has been shown that 24-week study, it has comparison of physician-guided titration compared to the patient-guided titration. Surprisingly, it has been found that the patient titration led to a better control in A1C at 24 weeks of decrease of 1.4% versus 1.2% in physician-led titration. So it is not that we can also, patients can also be trained or can be told about how to do the titration about a basal insulin. Now, the importance of SMBG, we all know that SMBG is very important in titrating the doses. Now, this patient at the third visit after titration of basal insulin, the fasting plasma glucose has come down to 122 milligram per deciliter, and 2 hours postprandial meal has come down to 148, almost becoming normal. So what target we are trying to achieve, we could able to achieve in this patient by just up titrating the basal insulin. Now, after 2 years of the same patient, you find that there is the A1C has again worsened to 7.6%, with the postprandial showing that there is increase in postprandial glycemia. So what next we should do is we should control the postprandial glycemia. So basal intensification with prandial insulin, how to go about it? They say that ADA says that intensification of treatment should not be delayed in people with type 2 diabetes. Intensification of prandial insulin should be based on patient needs. One should not be very dogmatic about it. So that's why it has been said that if somebody is starting with a Basal-plus, giving the prandial insulin to the one of the major meals or the largest glycemic excursion, then it is a more flexible and you can give the more physiological way of dealing with the rise in postprandial glycemia. So how to go about it? In many patients, it may not be possible to even to know that which is the postprandial meal which has to be highest excursion. Of course, this can be, we can monitor post breakfast, post lunch, and post dinner for maybe around 2 or 3 days and find out which is the largest meal which is causing the glycemic excursion and initiate a insulin, prandial insulin to the largest meal. But sometimes it has trials have also found that even without knowing that if it is not possible, even if you control the breakfast with the prandial insulin, it has been found that there is a decrease in A1C, and it seems to be a better option it seems to be a reasonably good option in patients where it is not possible. Now, Basal-plus compared to the premix intensification, how does they fare? There are many trials which are comparing the Basal-plus, starting with the Glargine plus one of the Prandial insulins, or increasing the Prandial insulin to Basal-bolus. And the trials have shown that these are all are non-inferior trials, giving the Riddle, Esner, and Vora et al. These have found that there is no, these are non-inferiority trials, but the only thing is that the risk of hypoglycemia is less in people with basal plus compared to the premix insulins. Also, the weight gain seems to be less with the basal plus. So sometimes autonomy study has shown that even the monitoring and titration of the patients with even the postprandial insulin can also be, you can also control the postprandial hyperglycemia by giving the pre-meal insulins. Also, patients can monitor by autonomy study where insulin lispro has been used to actually titrate their doses. So the last is how does the basal bolus? Many patients might actually may not be, some of the patients might not be able to control with basal plus. So they need to change over to the basal bolus therapy. And comparing with if you compare with the premix insulins, it has been seen that this is a lay study where insulin glargine was given along with the glulysin compared with the premix insulin, the 9-month study. And it has been found that people on basal bolus insulin, it has been found that there is a decrease of A1C of 2.27% compared to 1.7%. And the chances of hypoglycemia seems to be comparable in both the groups. So it seems that where it is really necessary to go for basal bolus, if it is intensification is not adequate with basal plus, we need to go about for basal bolus rather than, of course, there is other option is the premix twice daily. We can go for premix thrice daily. Now, there is insulin degludec has come out like anything. So there's trials where it has been co-formulation of insulin degludec aspartate has been compared with the glargine plus aspartate, and has been found that A1C levels, they are not significantly different, but definitely the hypoglycemia risk is less with degludec compared with the glargine. But the cost-wise is one of the inhibiting factors in people initiating on the degludec. So finally, I just want to tell about the meta-analysis. Try to look into various methods of intensification of therapy. So you have got a basal plus OAD with premix compared, basal bolus with versus premix, and basal bolus versus premix twice and thrice daily. You find that if you are comparing basal bolus plus once or basal bolus versus basal plus OAD compared with the premix insulin, you find that these are non-inferior and the A1C difference is not much. But when basal bolus is 3 times has been compared with the premix twice or thrice daily, the A1C is better with the basal bolus compared with the premix. And basal bolus and even the whole of the group, if you find that there is hardly any difference in the A1C levels between the whole of the group comparing the basal versus premix insulins. Now, regarding the hypoglycemic risk, you find that hypoglycemia is less in people who have been initiated on basal or basal bolus compared with the people on premix insulins. Also, the weight gain is also less with these people with this thing. So many times, some of our patients who are, there should not be any difficulty in initiating and intensification of treatment in people who are inadequately controlled with oral drugs or with the insulins. Then we need to up titrate to adequate level, and unless that is done, we will not be able to achieve. And one of the studies in India has found that the A1C level of less than 7% has been found only 19.7% of our type 2 diabetes patients, indicating that many of these patients were not adequately titrated or up titrated to achieving the glycemic goals. So in our patient, because at 2 years, he has been found to have the uncontrolled A1C, he has been initiated with 10 units of Prandial insulin, and which has been up titrated to 16 units. You find that over the period of 3 months, 2 years, 3 months, you find A1C has come down from 7.6 to 6.9, and fasting has come down to normal, and post-meals glucose is also come down to normal. This again shows that You can start with a basal insulin. You can add a prandial insulin as a to a largest meal or maybe breakfast in some cases. And if it is still getting uncontrolled, you can intensify the treatment with basal bolus therapy rather than to premix insulin. But I must say that premix insulins are very easy to adjust, but the risk of hypoglycemia and weight gain, these are the two main issues in people initiating on premix insulins. So key messages to summarize: titration inertia due to fear of hypoglycemia and weight gain leads to inadequate insulin up titration and poor glycemic control. Timely basal intensification critical for sustained glycemic control and mitigating the adverse metabolic legacy effects. Systematic yet patient-friendly dose uptitration strategies with basal insulin helps achieve the glycemic control, and Basal-plus may be an effective alternative to premixed intensification approach, especially in terms of better safety and flexibility. So I thank you all. Thank you again.
Nice.